Okay. Here is Dr. Conroy. She is the president and CEO of Dartmouth Hitchcock Medical Center. She went to medical school at the Medical University of South Carolina and did her residency in anesthesiology there as well. Her work at Dartmouth Health has included creating additional patient beds and also creating an ambulatory surgical center as part of the hospital network. One thing that she's really passionate about is advocating for women in leadership, and she founded Women of Impact, which aims to support female women leaders in healthcare. So today she will be talking about challenges facing the academic center as well as some of the points that we were interested in. So here she is.
Okay, great. Well, thank you. And I think you have given me a lot of really interesting topics to talk about. It would probably be helpful to kind of just start with my career journey just briefly, because it will kind of give you my perspective. We all kind of see the healthcare system from our own lens. And it was actually at the Medical University of South Carolina when I first got into departmental administration as a department chair in 1995, and then moved into leadership roles in the hospital, the college, and the practice plan in 1998. And it was interesting. My reflections back then that academic medicine was not actually really efficiently run. There was a tremendous amount of waste. It felt like there wasn't any standardization in how we delivered care or how we ran our operations. And in 1998, there was a legislation called the Balanced Budget Act, where the federal government actually made significant cuts in a lot of programs that hospitals depended on. Certainly Medicare and how Medicaid was distributed, and also funding for graduate medical education. And a lot of that happened in 1998. And 50% of the teaching hospitals across the United States went into the red immediately. So, in fact, it's one piece of legislation that was more effective than any of the leaders thought it was going to be, and they saved so much money. They actually did the Reconciliation Act, and they rolled a lot of it back. But it was the first wake-up call, I think, for medicine that we had to be more efficient. People started really thinking about medicine as a business then. I would say before that, not so much. People were a little bit fat and happy. You were paid percentage of your charges, and your charges had some relationship to their service, but just like now, not always exactly reflected of the effort or the costs for delivering the service. And people started saying, wow, we actually have to approach this with a much more business perspective. And they started doing that. We started thinking about length of stay. We started looking at the cost of delivering care. Up to that point, people didn't really look at the costs. We started in anesthesia looking at the cost of our anesthesia drugs. And I think I was doing an infusion for a neurosurgery case. And it was a new narcotic. And the pharmacist came in and said, I just want to let you know that you've already used, $2,000 worth of this narcotic, which was kind of a surprise to me. And we started thinking about that constantly. And I think that was an important inflection point for medicine. We started really reflecting on our costs. But just like in any other industry, there's often kind of sine waves of a lot of attention on something and then much less focus on it. And I would say when you kind of track through everybody recovering from the Balanced Budget Act and into early 2000, hospitals and health systems seem to do pretty well. Uh, there were a number of bumps. There was a recession in 2008, and we've had a series of recessions. But what's fascinating is that healthcare actually has been reasonably recession resistant, meaning people still need health care. You still get paid by the insurers. It's not something that's a preference sensitive item in the economy. That's something that people actually need. And it wasn't really until much later that we started to actually, I would say it was probably in 2008 when the housing market really burst and the economy took a significant nosedive, that hospitals for the first time started feeling that they were vulnerable to the economy. And in 2008, a lot of the community hospitals really struggled. When people had to make decisions, they put off elective cases. They didn't have their hips replaced and they didn't have their knees replaced, things that were not necessarily urgent, but improved their quality of life, but they felt was something that they could actually delay. Academic medical centers, however, still do pretty well because most of the patients we care for are not really having elective procedures. They're people that are incredibly sick, have emergency cardiac or neurosurgical procedures that are um, are life-saving for them, and those things can't be delayed. And that was interesting. At that point, I was at Atlantic Health in northern New Jersey. I was the president of Morristown Memorial Hospital. And um, you could actually see that happening. Um, and, I'd have to say, we were really kind of concerned about our volumes, et cetera. At that point, I actually went to Washington, D.C. in 2008, and I joined the As- Association of American Medical Colleges, and I was their chief healthcare officer. And at that point, I actually got to look at teaching hospitals across the country and academic medical centers and see how they were doing financially. And we have an incredible database that we can look at the financial performance of teaching hospitals across the country. And that's when I first made that observation that they had really been pretty resistant to a lot of the impacts of the economy compared to the community hospitals. But like most of the economic challenges we face, it's a little bit time limited. And really, after about a couple of years, most of the hospitals had readjusted both their case mix as well as where they made their investments, so they were actually able to recover financially. um, After my tenure at the AAMC, I went back into operations at Leahy Hospital Medical Center in Boston and then up here to Dartmouth Health. And over the 25 years of being in hospital administration, there are a couple things that, um, you know, I would characterize about hospitals and health systems that probably the average individual, the average medical student, the average physician, and probably even the average policymaker is not aware of. Number one, our revenue streams have changed significantly over the last 25 years. We used to pay for our expenses based on what we were paid for our medical services. That is no longer the case. Our physicians cannot cover their salaries with what they receive for professional services. Just can't happen. Any large physician group actually has to be either supported by technical revenue, meaning they own the lab services or they own the ambulatory surgery center, or they have a partnership with an organization that shares technical revenue with them. But and our physicians are very efficient. They work really hard, but they cannot cover their salaries. The second thing is that um, as we focus on clinical revenue, um, how we manage the rest of our business makes a huge difference. When you think about our pension portfolio, our investment portfolio, all of the equipment that we're depreciating on an annual basis, all the investments we make to actually improve our facility, to build new facilities, to add new equipment, our capital spend on an annual basis. All of those are levers that can be pulled and modified. So when you face a drop in your patient service revenue, there's a way for organizations actually to make sure that the financial status of the organization is stabilized. I would say we also receive revenue from other sources. Our Medicare revenue is not just for delivering services to people over the age of 65. We also receive money from the federal government to educate future physicians. It's called direct and indirect graduate medical education funding. And it is significant in organizations. It is tens of millions of dollars to every single organization every year, depending on the size of your program. I would say that we receive discounts from pharmaceutical companies, and it's a program called 340B. And especially if you're a disproportionate share hospital, meaning if you provide a certain amount of care to people who are underserved, and it's measured by your Medicaid days, you actually get substantial discounts on your pharmaceuticals. So you can actually continue to serve that population of people that are on Medicaid. And again, that is significant because it just doesn't affect that patient. It affects all the patients that actually visit your facility. And in fact, for many hospitals who used to be shedding low contribution margin services like pediatrics, OB, behavioral health, if you look across the country, those programs were always the first ones on the chopping block if a hospital was facing financial challenges. You know what? The 340B program for many hospitals actually offsets the losses of those mission-based services. And I've said to a number of people, even though the federal government doesn't pay for the 340B program, it's supported by the pharmaceutical companies, and they don't like it. They would like to get rid of the program, but it's done more to support those Medicaid-heavy services than anything we've ever done in this country. I would say the federal government would touch that at their own peril. And there is no resistance now when you're asking people to expand their behavioral health programs and to try to create maternal safety nets across the country. Because with 340B, you can actually break even on those now. I would say many hospitals and health systems also have alternative sources of revenue. They have invested in ambulatory surgery centers with physicians and sometimes without, often in geographies that maybe they don't really have a patient care base, but they are thinking about other revenue sources. Hospitals and health systems now move patients around, and those transportation companies often either cover their costs and or actually create revenue that supports those services that don't cover their costs. And then finally, many hospitals and health systems have their own insurance plans. And with their own insurance plan, they actually are moving money from one pocket to the other. So if you actually manage a patient population really well in your insurance plan, you have a positive margin, and that can actually be used to cross-subsidize a service that maybe doesn't actually cover its costs. So if you just think about the revenue streams, they're actually not very straightforward. And I could, the regulations and the infrastructure that actually helps support hospitals is kind of a master class in itself. Sometimes you realize how important some things are when um, something happens or somebody makes a decision and they don't appreciate the implications of it. I'll give you just two examples. In Massachusetts, I think about 10 years ago, um, Mass General purchased a hospital on Nantucket called Nantucket Cottage Hospital. And what that did was actually set what was called the rural floor for the state of Massachusetts and incorporate that into the Partners Health system. And what that did was actually shift money within Massachusetts from um, a, a number of the hospitals to Partners. And Partners net by acquiring that facility received an additional $48 million in revenue for at least 2 years out of the pockets of the other hospitals in Massachusetts. I mean, it is some of these vagaries of the federal and state regulatory and legislative process that people don't understand completely. The second is the area wage index. And, it seems counterintuitive, but it's better for us to pay our employees more and to actually charge them for their health services rather than, I had said, can we give some things to our employees for free? And it actually props up the area wage index. It doesn't just benefit us because it's part of the calculation about how we get paid, but it also benefits all the other hospitals in New Hampshire. And so for you lawyers on the phone that are thinking about getting into the kind of regulatory and policy and legal aspect of healthcare, I mean, healthcare law is a fabulous field that is, you truly need the expertise of individuals to really understand the impact of the regulations. And this is important not just for um, kind of our Office of General Legal Counsel, but it's also important from a policy perspective. Because when you go to talk to your legislators at a federal and state level and advocate for something, you want to know what the implications of that are. And sometimes it's not immediately apparent. And so all of our policy people actually have to have a legal degree. And they have to understand the regulations and they have to understand the impact of all the policies that we're actually advocating for. And so it's a whole nother field in itself. And if you want to get into research, the regulatory aspect of doing research in an academic medical center is a whole different subspecialty. We are very regulated, not only from a care delivery perspective, but when we do research for the federal government, there is very specific expectations on how that research is going to be conducted and the research operations that's going to both support that research as well as distribute the money from the federal grant to support that research. So it is, you would be surprised how much of our time is actually spent on legal and policy issues and not necessarily on care delivery issues. Um, I think when we talk about managing hospitals, and a lot of people ask me about, my job, how did I get here? What are the skills and talents that I needed? I would say it falls into a couple of categories. Number one, I never expect that I'm the only person that knows the answer in the room. And it's really doing active listening and also encouraging every member of your team to speak up and participate. That doesn't mean you have to have a really good team. And as a leader, you need to find the right people. And if they're not the right people, you have to ask them to step out of the role. And you have to remember that it's not about you, but it's about the future of the organization. And I've had to do that. It's the least favorite part of my job, believe me. But I do always remind myself that it's not about me. And a lot of the people I ask to step aside are really good people, but they have to be able to do their job. And um, and that's kind of one of the critical aspects of their role as a leader in the organization. Um, I would say this second thing is really understanding people. And I mean, all my executives are wonderful, but they got some quirks going on. Some of them are introverts. Oh my God, I have more introverts than I thought I would ever have in my team. I inherited a lot of people when I came, and I didn't just sweep the decks. A lot of people do that when they come into organizations. But I spent some time really understanding the talents of the individuals that I have. And they're not all like me, which is fine. Um, but they all have really content experts. And I would say their longevity in the organization is something that needs to be appreciated. I have some people that have been here for 37 years and they know the organization. They have done almost every job in the community group practice organization. That history is actually really, really important. Probably the most important thing is they don't begin every um, sentence with, well, we tried that before, or we've already examined that. And they're always willing to kind of look at things with a fresh eye. But I would say it is about managing people and making sure that your team actually works together, trusts each other. I I am a little bit like the den mother, and people come and they want to confide in me something that is about another member of the team. And I said, well, I'm happy to listen, but you have to go tell them how you feel about what they did. Um, I said, that's your responsibility. And sometimes I can actually guide them how to have that conversation in a way that supports a better relationship rather than damages a current one. I would say I've been in organizations that have been nail biters, where we've had to cut millions of dollars from the organization. And I've had to do reductions in force. And that is horrible. Eh, You know, you, I feel it's sometimes a failure of our management when we actually have to go in and remove layers in the organization or remove people from their jobs just to stay financially afloat. And you impact, I mean, everybody's human and you impact their lives in ways that you can't completely appreciate. And so I'm actually pretty cautious about how we expand and add jobs because I never want to add a job or create a program that have to close in 2 to 3 years because of financial constraints. And as a leader, you have to consider that. Even though we have to report to our board every quarter, they do track our financial performance on an annual basis. Anybody that issues us debt, we have to do quarterly filings. And we're accountable to a lot of people for our financial performance. At some level, you need to take the long view. And it's important not to overreact to a one-time financial hit that you can mitigate over a couple of years. And organizations that do that, create a culture that is, I would say, um, it feels unstable to your employees. And make no mistake, we are a service industry, and our employees, which mean our staff and all of our providers, our physicians, our advanced practice providers, our nurses, we are only as good as the people that are taking care of patients on the front line. And our goal is to make sure they're appropriately trained, that they're supported, that they can just come to work and take care of patients rather than worrying about things that would be distracting for them. And that's our role as an employer. Now, a number of those people actually aspire to leadership. So we do invest in leadership training programs for them. And that doesn't mean that we don't want them to know about costs or we don't want them to be aware about the constraints in the organization. But there are going to be some that will actually want to move up to leadership. And our job not only is to create the right teams, but also develop emerging leaders. When we talk about what challenges are facing hospitals, the industry, well, I guess we'll call it a field because we don't like to be healthcare. We don't like to be called an industry, but the field of healthcare. Um, I would say that there are a lot of differences on the challenges that they're facing, and it depends a lot on their local economies and regional economies. So I'm going to talk about the regions that you guys are training in right now. So I would say we have a lot of people from New Jersey, and having run hospitals in New Jersey for 8 years, New Jersey has pretty skinny margins. If you had a margin of 1 to 2% in New Jersey, you felt actually pretty lucky. There's a lot of competition in New Jersey, and there's a lot of competition with New York City. The state is really populated. I used to drive like 30 minutes and pass 3 million people. And how you deliver services and how you develop your workforce is going to be really different in New Jersey than it would be, let's say, in rural New Hampshire. You have a pretty supportive federal legislation in New Jersey, but you flip back and forth on your governor, blue, red, blue, red, blue, red. And it really depends on the individual in terms of how favorable they feel for hospitals. Graduate medical education in New Jersey, for the most part, is actually distributed across a lot of hybrid hospitals. They're teaching hospitals, but they're not academic medical centers, although that has changed in the last few years. I know the University of Vermont really well. We actually meet with the leaders from the University of Vermont and Maine Health 3 times a year. We're all rural. We've got some small size cities in our geographies, but our population is old. We say we're old and we're cold. We're the 3 oldest states in the nation and only getting older. Vermont has an interesting challenge that in a couple of years, there'll be more retired people in Vermont than there will be working citizens. And that's a tough flip. How are you going to actually support the programs across the state? I know a lot about Tulane, and actually, I was very good friends with the CEO of Ochsner, who went off to be the head of Sutter Health. And it's interesting. Ochsner after Katrina really actually expanded into a vacuum. There was a vacuum of organizations that actually wanted to reconstruct the healthcare infrastructure in New Orleans after Katrina, and Ochsner really stepped into that void. And I'm going to tell you, their margins were less than 1% for a long time and sometimes negative. But it's worked very well for them now. I mean, they have an incredible network across the state of Louisiana. But they took a lot of risk during Katrina. And it was calculated risk, but it turned out well for them, which I'm really glad about. I do know a little bit about Florida. Florida health systems are really interesting. My sister used to work for Optum, and she was a systems engineer, and but she was a little bit involved on the insurance side in behavioral health. And it's funny, she would talk about Dade and Broward County. That healthcare utilization was so huge there. They had a different category for them with the insurance companies. So the utilization of healthcare in South Florida is crazy. It doesn't follow any other patterns that are followed across the rest of the country. And there are probably many reasons why it developed to be that way, but the Medicare spend in South Florida is like the highest in the country, people say. So it's a little bit of a tale of two cities because there are a lot of areas of Florida that actually the spend is a lot lower. Um, let's see, Stony Brook's Steve. Uh, I know a lot about Stony Brook. We just recruited your cardiac surgeon to come up here. He's a rock star. Stony Brook, and I think your president is going to Yale. Is that right? Yes, yes, she is. Stony Brook's done a nice job though um, over the last 6 to 8 years. And I knew the previous head of your health system. He left in like, I think 2010, 2011. It's Long Island is really interesting. You've got Northwell, which kind of gobbles up most of Long Island. And then you've got Stony Brook, which is um, really New York state supported network, but probably the most efficient and profitable ones of the three New York state hospitals. But um, let's see. I know a little bit about Texas. It's interesting. I actually interviewed for a job with Ascension and actually went to Waco and Austin, Texas to actually look at their facilities there and decide whether or not I really wanted to work for the organization, which ended up being a no. But the market in Texas is also super competitive, more than people would appreciate, with a lot of like Baylor Scott and White, as well as the Dallas programs are kind of cheek and jowl with each other. And it's a market where both access and quality, as well as the moniker of the academic medical center, is actually super important. Um, let's see. And I know just a little bit about University of Louisville. Um, I think the University of Louisville has kind of gone back and forth on their hospital affiliations. Louisville is a really interesting city, and there have been some, and you find this in certain areas of the country, kind of battles for prominence of the academic medical center, and but trying to identify where is the kind of network of clinical facilities where people can train. And that sometimes becomes kind of um, a point of contention and debate. And I think Louisville is one city where I think you have maybe do you have three competing health systems there? Yeah. And it's almost like it's been that way for a long time. So you've kind of got a standoff between the three. There are a couple other areas of the country that are like that too. I mean, people say, what happens when a region actually starts to flip and consolidate and really start to focus on costs. And they say there's usually some precipitating merger that all of a sudden kind of disrupts the balance of power between three separate institutions in the organization. And then when that happens, people start to consolidate and then start to really deliver value. And it's interesting. Another city that's a little bit like that is St. Louis in Missouri, where the health policy people have looked for a long time at what actually have gone down for inpatient care when you think about the amount of spend. actually for Medicare has been pretty level in the hospital for the last 10 years. And we've become very efficient in the hospital in terms of hospital care. And every single year, they're decreasing physician compensation for their professional services. But the big increase is in pharmacy. Our specialty drugs are just, you know, are driving the increase. I would say when we look at how costs are increased, it is really associated with the increasing the complexity of the procedures we're able to offer patients, as well as the drugs that we're able to offer patients. It was probably 10 to 15 years ago. I don't know if any of you remember when the first drugs came out for hepatitis C, remember? They were $96,000 a course of treatment. People were horrified. And yet you could cure hepatitis C with those drugs. And as we thought about how we justified it, we just said, we're preventing a liver transplant that, could cost $300,000 or $400,000 down the road by actually treating hepatitis C in an earlier stage. But granted, for a lot of insurance companies and employers, it was a big gulp for them to cover $96,000 a year for a drug. And, that's nothing now. I mean, I've got drugs that are $3,000 a pill. I've got treatments that cost $1 million, and they're more in the queue when we think about the innovations that are actually coming down the pike in immunotherapy, as well as management of chronic diseases. When I look at my spend for all my employees, when I was in Washington, D.C., the top spend was AIDS drugs because there were a higher incidence of HIV in Washington, D.C. than any other metropolitan area. So not a surprise that was my highest spend. But now my highest spend are oncology drugs, drugs for multiple sclerosis, drugs for a lot of our common conditions that are incredibly expensive, and the condition is really prevalent within our organization. A lot of people ask about the electronic medical record. It's a blessing and a curse. It's a blessing because we finally have all the data in one place, and our patients can go anywhere and our physicians can go anywhere and access their records. It is so easy to access your record now. I can do it on my phone and look at my labs. When you think about how it saves time and improves communication to give people their labs, right when they're available, it's amazing. We kind of take it for granted, but it is a curse because our providers are spending a lot of time after hours completing their records. Now, there is a solution on the horizon because a lot of the new generative AI modules that we're using Ambien, and I think Ambience, and there's one called DAX, that are being developed by companies to actually automatically translate what you say into the record. And it's fascinating because people that are using it say it totally changes their interaction with the patient. They're looking at the patient, not looking at the screen. It's pretty accurate after using it just a short period of time. And what's interesting is they're so used to the framework of the written note or the computer note for them to actually just look at the patient and freeform speak requires a different amount of rigor. However, their charts are completed by the end of the day. And if we don't actually embrace a lot of these generative AI tools, I mean, we will burn our clinicians out. They can't keep up with this. In creating the electronic health record, we actually have pushed a lot more work on the physicians that they didn't have before. And does it create efficiencies, eliminating the need for people or positions that are no longer necessary? Maybe, but a lot of that is loaded on the physicians. But I think there's hope on the horizon with a lot of the generative AI tools. Um, I'd like to remind people that when they say what keeps you up at night, um, things like COVID, none of us saw it coming. Um, we had the first case in New Hampshire up here, but still the first wave didn't really affect us. I have to say we invented social distancing up in New Hampshire, so we were actually really lucky up here. Very few people died at our hospital. And yet I know that it was a horror show in a lot of hospitals in across the country, that especially served um, disadvantaged populations who had cramped living conditions, didn't have appropriate access to care. And it was horrible for both the families and the patients and the providers. But one thing it did teach us was that we could make decisions really quickly if we eliminated a lot of the bureaucracy. We had an incident command team, and they made decisions without us. They didn't have to ask Mother May I for anything during the heat of the pandemic. I mean, the only time I intervened, which was when they were going to shut down everything. They said we decided to shut down all of our elective procedures. I remember it was like March 10th or 11th of 2020. And I said, okay, this might be a decision above your pay grade. And so the CFO and I actually went in and met with the incident command team. And they talked about their thinking about why they felt they needed to shut down everything. I mean, we shut down 75% of our business immediately. And the CFO was trying to calculate how much money we could lose on the back of an envelope. He goes, well, I think we can lose $250 million and still survive. And I think we lost far more than that. But um, it was the right decision because there were so many unknowns, and we didn't want to place patients, employees, and the communities at risk. But many other decisions they made were just brilliant, and they made them on their own. They stood up a KN95 reprocessing plant. They repurposed all the staff that were no longer taking care of patients in the operating room to supporting staff across the organization. They purchased $11 million of PPE, a lot of it from China, and figured out how to get it over here so we could all be protected. Um, they put policies in place in a flash. And what I'd love to be able to do is say, well, what did we learn from the pandemic, and how can we actually use that to eliminate a lot of unnecessary bureaucracy that we have right now? Because we don't want to go back to the original bureaucracy, which is, how healthcare organizations administratively are run. But how can you actually be nimble in the right areas at the right time to really execute more efficiently and effectively than we had in the past? I would say out of the pandemic, the hardest part for us was when people started resigning in 2021, I think. And, it was amazing how many people just left healthcare. They were either burned out or um, um, were just exhausted. And that didn't just hurt us, it hurt everybody. Now, people are coming back now, um, which is a good thing. But it's going to take us probably 3 to 5 years to really recover from that. Um, you know what? I'll just say a final thing about women in leadership. Um, I have been a real proponent of women in leadership for a long time. The number of women we have sitting in the C-suite and definitely sitting in the CEO role across the country has really not budged over the last 30 to 40 years. And in fact, it'll take about 100 years for us to have parity in the C-suite. I don't want to have a conversation around whether diversity is good or bad, because we know it's good. We know not only gender, but racial and ethnic, as well as, diversity of backgrounds helps teams make better decisions. We know that. It's been proven again and again in Fortune 100 and Fortune 500 companies, and it applies to healthcare too. But we have to be really intentional about putting people of color and putting women into leadership roles, or we won't get there. It's too easy to talk about fit or just work within your own restricted networks, and you don't actually get to see the talent out there. We have totally changed our recruiting processes, and we have people write diversity statements. And you know what? We have incredible diverse pools of our applicants now. We actually blind the applications so you can't tell race or gender when they go through the application process. So they're all evaluated based on their merit and their credentials. And it's amazing once you blind those applications, the diverse pools you get. And so when anybody says, oh, well, there aren't any qualified candidates out there, I say, I don't believe you. And you just really have to be intentional about really getting your great pools. So I've been talking for a long time, and I think we only have about 5 minutes left. Did I hit most of the topics that all of you were interested in? I feel super fortunate to actually be up at Dartmouth Health. Looking at what's going on with a lot of the struggles of hospitals in Massachusetts and Rhode Island, and the whole thing about private equity and healthcare is a little bit frightening for people. I wonder where it will end up. I mean, we're seeing Steward hospitals declare bankruptcy in Massachusetts, and I think there are hospitals on the brink in Rhode Island. When hospitals fail, you actually create huge holes in the safety nets for people in the community. If you think about it, what would happen if you call 911 and nobody shows up? Or if they show up an hour late, they can't take you to your local hospital because there's already a queue at that local hospital of ambulances that can't get in to discharge their patients. I mean, there are certain things that the community actually depends on us for. They expect us to be there during those emergencies. And we do have some stress fractures already in our healthcare system. Sometimes it's hard to get an appointment when you want. Sometimes you have to wait a day to get your medications. And sometimes you have surgery that's delayed because we don't have enough staff to, add another operating room. But those are symptoms of a much kind of greater challenge, which is, I think the healthcare system is under a lot of stress right now. And that's why it's kind of nice to be in New Hampshire, because our environment is easy enough to kind of put our arms around it and understand all the dynamics. We don't always come up with the best or the fanciest solutions, but we actually are there to take care of the patients of New Hampshire and Vermont. And we are the largest provider of care in New Hampshire and almost neck and neck with UVM for Vermont. And that is actually our mission. We're supposed to be there. And that's something we take very seriously. So anyway, questions? Well, you know what? Congratulations for finishing year one of medical school, or getting the launch position, Kaya, for maybe going into science or going into the legal regulatory perspective in the future. Healthcare is the best career ever. It is. I mean, Chris, you've had another career and you chose to go into healthcare. You know what? Every day you will save somebody's life. You may not know the impact that you've had on people, but they know it. And some days you will know you've saved somebody's life, but some days you'll have saved somebody's life just by being a great physician, or being a great lawyer, or being a great, you know, understanding the regulations and creating programs that help people that are underserved, you can make a real difference in healthcare that you don't get that positive reinforcement from many other professions. So thank you. It's a hard road. It's a hard road. You guys are just starting. We think residency is easier than it was before, but it's still rough. 80 hours a week is still a lot. And I do remember driving home after an anesthesia night on call, and I could almost feel the cotton pillowcase on the side of my face. I was so tired. And but at the same time, you are just learning so much as a resident. And it's a privilege and an honor to when people let you into their lives, like they will every single day. So anyway, well, thank you. It's been great meeting all of you.
Thank you. Thank you.
Thank you very much.
Thanks so
Thank
much.
you.
Thank you.